Welcome to the StudyNeuro lecture series. Today, we'll cover a step-by-step bedside exam of cranial nerves 5 and 7. By the end of this session, you'll understand their key functions, spot common clinical deficits, and apply this knowledge at the bedside. Cranial nerve 5, the trigeminal nerve, controls facial sensation, chewing, and the corneal reflex. Cranial nerve 7, the facial nerve, governs facial expression and taste from the front two-thirds of the tongue. These nerves are often affected in Bell's palsy, trigeminal neuralgia, stroke, facial injuries, and head trauma. Mastering them is essential for accurate neurological exams and clinical localization. Follow youtube.com/StudyNeuro for more lectures, neuroscience updates, and clinical insights. When examining the trigeminal nerve, you're really assessing two main things: facial sensation and jaw strength. This nerve supplies almost all sensation to the face and also controls the muscles used for chewing, so abnormalities here can be very localizing. I usually start with sensation. Using light touch only, I test the face systematically and always compare one side with the other. It's important to focus on the medial parts of the face rather than the sides, because dermatomes overlap laterally and can give a false sense of normality. I'll touch the forehead to assess the ophthalmic division, the cheek for the maxillary division, and the chin for the mandibular division. As I do this, I ask simple questions like whether the patient can feel the touch and whether it feels the same on both sides. Once sensation is assessed, I move on to the motor component. I ask the patient to clench their teeth while I feel the masseter muscles on each side. I'm checking for symmetry, bulk, and strength, which reflects normal function of the mandibular division. Reflex testing isn't routine for every patient, but it can be helpful in specific situations. The jaw jerk may point toward an upper motor neuron problem, while the corneal reflex, tested gently with a cotton wisp, assesses the trigeminal nerve as the sensory input and the facial nerve as the motor output. In a normal exam, facial sensation should be equal on both sides across all three divisions. Jaw clenching should be strong and symmetric, and any reflexes tested should be appropriate. Clinically, the key takeaway is that careful sensory testing can help localize lesions to a specific trigeminal division. Jaw weakness suggests motor involvement of V3, and abnormalities in the corneal reflex can indicate pathology in either the trigeminal or facial nerve. Done properly, this is a quick but very informative part of the cranial nerve examination. When examining the facial nerve, our main goal is to assess facial movement and symmetry because this nerve is the primary motor supply to the muscles of facial expression. It is also especially important for distinguishing between central and peripheral causes of facial weakness. Begin by simply observing the patient at rest. Look carefully at the face for asymmetry, flattening of the nasolabial folds, or incomplete eye closure. Even before asking the patient to move, these resting features can give early clues to facial nerve dysfunction. Next, assess facial movements by asking the patient to activate different muscle groups, always comparing both sides. Start with the upper face by asking the patient to raise their eyebrows, then ask them to close their eyes tightly. Gently try to open the eyes to assess strength. After that, move to the lower face by asking the patient to smile and then puff out their cheeks, watching for symmetry and any air leakage that would suggest weakness. As you go through these steps, pay attention to both the range of movement and the strength of contraction. Normal function is indicated by smooth, symmetric facial movements, strong eye closure that resists opening, equal eyebrow elevation, and the ability to keep the cheeks puffed without air escaping. The facial nerve exam is particularly valuable for localization. Weakness involving both the upper and lower face points toward a peripheral facial nerve lesion, such as Bell palsy. In contrast, sparing of the forehead with weakness confined to the lower face suggests a central upper motor neuron lesion. Remember that effective eye closure is essential for corneal protection, making this assessment clinically important beyond diagnosis alone. Finally, use clear and culturally appropriate instructions. Simple commands like smile are often more effective and comfortable for patients. Cranial nerves 5 and 7 control facial sensation, expression, and oral motor functions. Knowing their anatomy and clinical signs is key for accurate neurological localization. Bedside exams of these nerves can reveal facial nerve injuries, trigeminal deficits, or central lesions. In Part 3, we'll cover cranial nerves 8, 9, and 10, including hearing, balance, swallowing, gag reflex, and phonation, and common deficits like vertigo, dysphagia, and hoarseness. Thanks for watching. Drop your key takeaway in the comments and like, share, and subscribe at youtube.com/StudyNeuro for weekly neurology and clinical updates. Stay